which of the following is responsible for galactokinesis? What do you mean by galactokinesis? So first thing is galactokinesis means milk ejection. Kinesis means ejection. So here answer is oxytocin, because oxytocin is milk ejection, or we can say galactokinesis. Galactokinesis. Second thing is, what about prolactin? So prolactin is galactopoiesis. So we term use galacto milk production, or so production or we can say galactopoiesis. Galactopoiesis. So clear? So milk ejection or galactokinesis. Kinesis means milk ejection. So its responsible hormone is oxytocin, and milk production, or we can say galactopoiesis, that is responsible for prolactin. Let's discuss next question. Here the question is, two medical students are planning to a trip to high altitude. They want to study the effect of acclimatization. Which of the following is not seen in high altitude during acclimatization? Not seen. So here main question is not seen. Do we get the polycythemia? So yes, polycythemia will be there in that case, because if you go to the high altitude, there will be hypoxic hypoxia. And what happened immediately after ascent? There will be hyperventilation. Because of the hypoxia, there will be hyperventilation, because hypoxia will decrease the partial pressure of oxygen, PO2 decrease, so decrease PO2. So peripheral chemoreceptor will be stimulated, and then hyperventilation. After that, there will be, because of the hypoxia, there is the increased erythropoietin. One thing is hyperventilation immediately after that ascent. After few days, after few hours to few days, there will be increased production of erythropoietin from the kidney, and because of that there will be increased polycythemia, and if polycythemia will be there, then obviously there will be increased hemoglobin count. So hemoglobin count will be increased. Then increased myoglobin, obviously there will be need oxygen need in the tissue will be more, because of the hypoxia there is increase of myoglobin also, because this is another form of stored hemoglobin or in the muscle, and they will actually bind oxygen and keep oxygen reserved for utilization in the crisis situation. So that again myoglobin will be increase myoglobin level. But what about the hypo? So here question is hypo. So this is going to be your answer, because this is not going to happen. So here question is not seen. Other thing we can say, there will be the high altitude ascent. So let's move to the next question. Here a 65-year-old man hospital complain of suddenly not making any sense while speaking. Because of the hyperventilation, there will be alkalosis for some time. It will correct it later on. Then because of that, there will be polycythemia, increased vascularization. New capillaries will be increased. Number of new capillaries. There will be increase in mitochondria, increased cytochrome oxidase. So these are the things which is going to increase in case of high altitude. If person will, but main thing is that hyperventilation will be there. Then erythropoietin layer will increase. So because of the erythropoietin, there will be increased polycythemia, increased hemoglobin concentration. Then again myoglobin concentration will also increase. Mitochondria level will increase. Then new vascularization will be there. Then in the tissue level, and then cytochrome oxidase will also increase. So these are the few effect of the. He is speaking quickly, but this not making any sense, means he is irrelevant talking he is doing simply. So that is the answer will be here is fluent aphasia. Why there is fluent aphasia? So we have different type of aphasia. So if there is any abnormality in the you can say categorical hemisphere, there will be uh, different type of aphasia. It may be fluent aphasia, it may be motor aphasia, it may be anomic aphasia. This type of aphasia, which is actually fluent aphasia, person is talking but irrelevant talking. So this is also called jargon speech. Jargon speech, or we can say neologism. We can also use term neologism or for fluent aphasia. So what is this? This is because of the damage in Wernicke's area, which is in the categorical hemisphere. We have Wernicke's or Broca's area. So Wernicke area damage, it lead to fluent aphasia. Person can talk fluently but without any sense. And what is motor aphasia? Motor aphasia, when person Broca's area is damaged or defective, then you can say there is a motor aphasia. Anomic aphasia, so here Wernicke area will be affected and fluent aphasia is the cause. So here answer will be fluent aphasia. Next question is thyroid hormone act via which type of receptor? Okay, so here answer is actually simple, is nuclear receptor. So thyroid hormone can cross in the cell and nucleus, they can directly act on the nuclear receptor. So thyroid hormone. But what are the other hormones we can act through the nuclear receptor? Vitamin D, first one, then vitamin A, then we can say thyroid hormone, and then estrogen, or we can say DATE. So we can say DATE, D for vitamin D, A for vitamin A, T for thyroid, A for estrogen. So we can remember like this DATE. Then what are the hormones act via cytoplasmic receptor? So use TAP or ATP. So TAP means T for testosterone, testosterone, A for aldosterone, and TAP, P for progesterone. So we got testosterone, aldosterone, and progesterone. These three are the can cross the cell and they act either testosterone, aldosterone, and progesterone through the cytoplasmic. Thyroid hormone can also cross, and vitamin D, vitamin A, estrogen can cross the cell membrane and directly act on the nuclear receptor. So simple. So just remember these things: just nuclear receptor and cytoplasmic receptor. Those who are on the nuclear receptor and cytoplasmic. These are repeated question. So here answer is the nuclear receptor. Next one is identify the hormone A and B giving negative feedback on hypothalamus pituitary axis. Hypothalamus. So here is the hypothalamus releasing what? Gonadotropin releasing hormone. This is going to the anterior pituitary, and here we have two hormone, LH and FSH, follicular stimulating hormone. So GnR is acting on the anterior pituitary and releasing LH and FSH. LH actually stimulate a Leydig cell and FSH Sertoli cell, and this is actually Sertoli cell actually releasing inhibin B, and this is the testosterone. Leydig cell will actually release the testosterone, and this testosterone is going to actually inhibit. So here these are going to feedback inhibition will be there. So they are going to inhibit LH, and not only LH, testosterone can also inhibit the gonadotropin releasing hormone. Here inhibin V is also going to inhibit the follicular stimulating hormone, inhibin B. So identify the hormone A and B. So A hormone is the actually testosterone and B is inhibin. Here A, or this is the B. So A is inhibin B, okay, inhibin B, and B is the testosterone, okay, like that. Or suppose this is A and this is the B, then this will, or suppose this is the B or this is A, then this is the testosterone, A is testosterone and B is the inhibin. So like that you have to answer, and this is also going to have positive influence on the Sertoli cell. So these are the hormone inhibin B here from Sertoli cell. There is a inhibin B, and this is going to inhibit the follicular stimulating hormone. And in Leydig cell, there is a testosterone, and which is going to inhibit. So in the adjacent graph, phase 1B represent which of the following property. So here property is elasticity, plasticity, contractility, and none of them. So here we have a intravesical pressure. So this is the obviously bladder pressure written here. So 20 centimeter water, 40 centimeter water, 60 centimeter water, and 80 centimeter water. Here we can say in the from zero graph here starting intravesical volume. It means volume in the bladder. So here 0, here 100 ml, 200 ml, then 300 ml. So this is around 50 ml, 400 ml, and 500 ml. Here question is 1V. So what is this about this one? 1A, we can say from 0 here, volume is increasing. This area volume is increasing, and at the same time pressure is increased. So suppose this is 10 centimeter water, pressure is slightly increased. After that you can say here 1B, 1A volume is increasing, slightly pressure is increasing. At this 1B graph is a straight line. You can say this graph is actually a straight line. Here volume is increasing. We can say 100 ml, then 200 ml, then 300 ml, then 400 ml. Volume is increasing and reaching to 400 ml from 50 ml, but pressure is not increasing. So pressure is not increasing. So pressure is not increasing. Only after 400 ml, the pressure is sudden rise of the pressure. So what is that? This is because of the, it means this volume is accommodated. Accommodated means you are increasing the volume, pressure is not increasing. So that is follows the law of Laplace, where the tension volume is increasing, and because of that radius is also increasing. So that's why tension is not going to increase. So that's why because of the this bladder muscle and smooth muscle of the bladder wall is showing plasticity. Plasticity means what? They adopting the new normal. Adopting. So you are increasing the volume. Suppose this is the bladder and ureter, fluid is coming, and this is urethra. So fluid is coming, and after that bladder wall is going to stretch, and not stretch, it will remain in that position easily. This is not elastic wall. The bladder wall is not elastic. They will increase as volume will increase. So they will increase their shape, change in the shape, and remain in that shape, and they will adapt that shape easily, and that is called plasticity, not elasticity. Elasticity means recoiling, like lung. If you stretch, and tendency will to collapse again, go to the initial position. But here this is plasticity, this tendency is not to go in the initial position. That's why they can accommodate more and more volume without changing in the pressure. Pressure will not increase, pressure will remain same till 400. After that, this is the maximum level. After that, there will be intense urge of uh, urination, and that. So 1A and 1B is actually plasticity. So this is B, plasticity, and this 2 is actually contractility. Okay, clear? Now, on injection of irritant substance, bradycardia, hypotension, and apnea was developed in the person. This presents which of the following reflexes? So what is the irritant substance? Irritant substance may be histamine, then serotonin, capsaicin, serotonin, capsaicin, capsaicin. So these are the some irritants which if you inject, and what they will produce some type of reflex, and this is actually nothing but actually visual uh, Jerry's reflex here. So visual J reflex is what? Bradycardia, hypotension, and apnea. Apnea, or we can say decrease the ventilation, or bradycardia or apnea, you can say. So here decrease bradycardia, hypotension, and apnea. So that is actually visual Jerry's reflex because of the injection of the serotonin and histamine, or any irritant substance if you inject, and that will actually reach to the ventricle. The receptor will be there in the ventricle, and that will actually response. In response, that bradycardia, hypotension, and apnea will develop. So that is called visual Jerry's reflex. So then what about the brain bridge reflex? So brain bridge reflex is nothing but if you increase volume, infuse large amount of volume, if you infuse suddenly the saline, or suppose any fluid, if you infuse in the large volume suddenly in the stomach, then in that case increase the heart rate, increase heart rate, and that is the atrial reflex. And what is the Cushing reflex or Cushing reflex? So this is the increase intracranial pressure. This reflex is seen in case of increased intracranial pressure. So if cranial pressure inside the brain is increased, it may be because of the tumor, it may be because of the stroke or hemorrhage, anything, or you can say head injury, the intracranial pressure will increase, and in that response of that there will be hypertension. Pressure will increase, and that actually systolic pressure especially increase, and sometimes diastolic blood pressure decrease in the diastolic blood pressure, or we can say pulse pressure increase in pulse pressure more specifically, or you can simply say blood pressure increased. So blood pressure increasing the Cushing reflex when intracranial pressure increases, especially systolic blood pressure will increase more, or sometimes diastolic blood pressure will remain normal or decrease sometimes. Okay, or pulse pressure will increase. So that is and at the same time decrease heart rate. Opposite to that, heart rate will decrease. So increase blood pressure and decrease heart rate, and ventilation sometimes irregular, sometimes increase or decrease. So irregular breathing pattern will say irregular breathing. Irregular breathing, ventilation you can say. So this is nothing but on injection of irritant substance, bradycardia, hypotension, and apnea was developed in a person. This response of the following reflex. So which reflex is this? So answer is basalt Jerry's reflex. So next is brain bridge reflex. What is that? If you infuse the large amount of fluid suddenly, and that volume increase, actually response, body will give response in the form of increased heart rate. Then here Cushing reflex or Cushing reflex, this is the increased intracranial pressure. Response to that, there is the hypertension and decreased heart rate. Heart rate will decrease, and pressure will increase, and that is the systolic blood pressure will increase and diastolic blood pressure will decrease. So these are the next question is glucose is mainly transported by GLUT2 in which of the following. So here question is glucose is transported by GLUT2. So here answer is where is the GLUT2 in which of the following? First is a small intestine. So let's draw a diagram. So suppose this is the intestinal epithelial cell, okay, and this is the intestinal lumen, you can say, or we can say, okay. So here intestinal cell, this is the kidney suppose, and this is the liver cell. First three will draw, and here we can add, okay, in the intestinal lumen, and then kidney. So this is the kidney, this is the intestine, and this is the liver, okay, and here the lumen, and this is the basolateral membrane. So basolateral membrane, blood vessel will be there. So here we have blood vessel. So this is the blood vessel, this is the blood vessel, basolateral or contralateral, and this is the lumen, this is the kidney, then again this is the kidney, and this is the liver, and this is the basolateral membrane. So we have two type of membrane, one is the basolateral and one is apical membrane. So apical basal membrane, or you can say luminal. Okay. So this is a lumen. Here we have, in case of intestine, we have SGLT1. So here we have SGLT. So here is a sodium glucose, and this transporter is known as SGLT1. So in intestine, SGLT1. In intestine, we have, in the luminal side, we have SGLT1, and in the basolateral side, we have say GLUT2. So in the kidney, so here kidney B, what is there? In the luminal side, we have again sodium SGLT. So this is the, suppose this is the SGLT, sodium and glucose. So this is the S kidney SGLT. And what type of SGLT is 2? In kidney we have SGLT2. Intestine we have SGLT1. And from the here, this is SGLT1, SGLT2. And from here again GLUT2, GLUT2. And in case of liver, we have here GLUT2 only. So this is the GLUT2, and here also we have GLUT2. Other tissue we also have GLUT2, but mainly GLUT2 is present in the both the side, in the liver. Here both the side, and absorption. Suppose absorption here is the, in the case of the small intestine, absorption food, if you intake of the food, and food will be reabsorbed with the sodium glucose SGLT1. Here primary absorption is done by SGLT1 in case of the intestine, and in the kidney, from the kidney, reabsorption will be done by the SGLT2, and not GLUT2. GLUT2 is the vasolator. They will secondary active transport, and they will go in the blood. So again, GLUT2 is present in the all the site, all the vasolateral movement in case of the intestine, liver, and kidney and liver. But SGLT in the luminal side, we have the, in the intestine we have SGLT1, and in case of kidney we have SGLT2, and in case of liver, in the apical membrane, we have GLUT2 in the both the side, and that's why here answer will be, most accurate answer will be liver and not kidney. So another question, we'll discuss the similar type of question. Which of the following glucose transporter is present in the basolateral membrane of the intestinal epithelial cell? So we have already discussed, nothing to say. This is the GLUT2 basolateral membrane in case of intestine, in case of the kidney, in case of the liver, everywhere GLUT2. Which of the following is correct about the Wolff-Parkinson's White syndrome? So what is the Wolff-Parkinson's White syndrome? It's nothing but extra. So this is the heart, SA node, AV node. Impulse should go like this: SA node to AV node to bundle of his Purkinje fiber, and then it's to the ventricle. But in some cases, we have some other channel in this, anywhere other channel, and that is the fast anywhere other channel. So extra channel will be there, and that is super fast. So impulse, while reaching here and cross to the AV node and to reach to the ventricle, before that, one side impulse will cross, and that impulse will go to the ventricle through that channel. Normally we don't have any channel other than the AV node to pass the impulse from the atrium to the ventricle, or SA node to the ventricle. Okay. But in that case, we have another type of channel which can conduct impulse faster than that AV node, and that actually cause depolarization. Because of that, there will be the P wave, and then there will be Q wave, RS complex, like that, and then T wave. So here will be the short PJ interval. So P to J interval, it will be not short, but will be same, remain same. So there will be the normal PJ interval. PJ interval will be normal because of that. So Wolff-Parkinson White syndrome, extra channel will be established, or it may be congenital. So extra channel will be there, or that channel actually pass the impulse. So any condition in which extra channel is established between atrial and ventricle, and that actually conduct the impulse faster than that AV node, before that AV node, and again AV node will pass the impulse and that will combine. Okay, so they will join with the initial impulse. Initial impulse from other channel pass to the ventricle, and then AV node will pass later on, and that will join. So that's why there will be like this type graph will be like this. The slope will be formed, QRS complex. So that slope type of thing will we get, and then they will T. PJ interval. Okay, so PJ interval will be normal, no change. Broad QRS interval, yes, there will be broad QRS. So this is the Q and QRS. Normally, this is the PQRS. Suppose this is the Q, so QRS, and then T. So this is the actually broad here. So broad QRS complex. So answer will be here. This is correct. Which of the following is correct? So broad QRS. What about the tall tented Tibets? No. This is no prolonged PR interval. No, there is no prolonged PR interval. So this is the PR interval. So PR interval as a whole, it will be the same because the this gap is actually here. So interval will be the same. So here is the same. So there is no change. PJ interval will be normal. Then broad QRS. Okay, broad QRS in the Wolff Parkinson White syndrome, extra channel will established, and that will actually pass impulse before the impulse from the SA node, or SA node will pass to AV node, and from SA node AV node, and then it should go to the ventricle. But before AV node will pass the impulse, some other channel, through some other channel, impulse will pass to the ventricle, and that's why deployment will start before that, and then impulse will come from the AV node, and which will join to the initial impulse, and that's why there is a broad base of the broad QRS interval. Clear? A 50-year-old man present with movement disorder along with development of cognitive and emotional problem. So here the answer, cognitive and emotional problem is the main thing. Which of the following medical disorder likely diagnosis? So simple is the Alzheimer's disease, because in Alzheimer's disease we have the cognitive impairment. And what about the Parkinsonism here? So Parkinsonism is always come with the some called bradykinesia, akinesia, or some type of rigidity. So always we will get the bradykinesia, akinesia, hypokinesia, this type of thing. Brady, bradykinesia, akinesia, or we can say late pipe rigidity or clasp knife spasticity. So rigidity or spasticity, this type of thing, rigidity, or we can say resting tremor you will get. So Parkinsonism is not the answer here. Here is the answer will be Alzheimer's disease, where the cognitive and emotional problem is the hallmark, we can say, in the Alzheimer's disease. And in case of Parkinsonism, you will always get the bradykinesia, akinesia, hypokinesia, rigidity, cogwheel rigidity, then late pipe rigidity, then resting tremor. This type of thing you will get the in case of the here also you will get the cognitive impairment, but the basic thing or main importance you should give the bradykinesia, akinesia, rigidity, tremor, like that. Then question is serosa layer is absent in, the answer is esophagus. So here the simple answer, serosa is absent, is a in the esophagus. Other thing we have serosa, but in the esophagus we have absent. So esophagus will be the answer. A patient presented with following symptom, there is the edema, feet, JEP could be traced up to mandible. Which of the following is the most probable diagnosis? So I am not going to discuss this question in detail. So answer will be the heart failure. Heart failure.